Hello, everyone, and thank you for joining us today. Before we get started, I wanted to remind everyone about the Meeting Hub tool that is available in the portal. This hub allows you to speak to fellow attendees throughout the conference. It can be found on the right-hand side of the main portal screen. By clicking View on the Meeting Hub, you'll be taken to a screen with all of the conference attendees' names where you can connect, live chat, or even video chat with your fellow attendees. So this session is Cutaneous Lymphoma 101 with Dr. Basem William. Dr. William is a hematologist with an internationally recognized expertise in hematological malignancies, lymphoma, T-cell lymphomas, cutaneous and systemic, drug development, and cellular therapy. He has been an investigator on over 100 clinical trials in hematological malignancies and cell therapy. He has published over 70 peer-reviewed articles, over 100 peer-reviewed abstracts, and 4 book chapters. He has previously served on the NCCN Guidelines Expert Panel in T-cell lymphomas. We are so excited to have him speaking to us all today. Please welcome Dr. William.
Thank you. Thank you, Autumn. It's always a pleasure to be part of the Cutaneous Lymphoma Foundation educational session. I'll try to make this overview brief to the point and allow an ample amount of time to answer your question to the best of my abilities. For those of you who are in the Columbus metropolitan area, I was previously at the Ohio State University, but now we're starting a new state-of-the-art program at OhioHealth, also based in Columbus. So cutaneous lymphomas are actually, they are skin tumors, but they're actually tumors of the immune system. They arise from lymphocytes, which are immune cells. The skin happened to be the second commonest site after the gastrointestinal tract for what we call extranodal lymphoma, lymphomas that do not live in lymph nodes. If you look briefly, lymphomas are generally characterized as Hodgkin lymphoma, which is Hodgkin disease. It rarely involves the skin, and non-Hodgkin lymphoma, which is really an amalgam of so many different disorders that are very different biologically. They behave very different way. And if they live outside the lymph nodes, we call them extranodal. And the skin happened to be the second commonest site for extranodal involvement after the gastrointestinal tract. There is an important concept also to understand. What we'll be talking about today is what we call primary cutaneous lymphoma. It means that these are lymphomas that are primarily based in the skin. They could start at the skin and involve other organs, but their main site of presentation is the skin. And these are classified according to the cell of origin. The lymphocytes, the immune cells, are either B cells that come out of the bone marrow or T cells that come out of the thymus. So we have cutaneous T-cell lymphomas and cutaneous B-cell lymphomas, and we'll try cover both in some detail. There is another term that's probably less relevant, but important to understand. It's called secondary cutaneous lymphomas. So these are primarily systemic lymphomas that are somewhere else in the body, and they could be in the lymph nodes, but then they are involving the skin as a secondary involvement. And these tend to be a bit different biologically than primary cutaneous lymphoma, although in some situations, I'll show you later, it's really hard to determine if what we're dealing with is primary and or secondary. So moving on, we'll start first talking about cutaneous T-cell lymphomas. So these are lymphomas coming out from the T lymphocytes. And there is a term that you're going to hear a lot. It's called mycosis fungoides. You could be diagnosed with that as well. We still use that term. It was historically described in 1806 by the French physician, Jean-Louis Marc Alibert, of a patient who have those tumors on his face, and they call them mushroom-like tumors. And initially, he thought that these were fungal infections, and there the term fungoids come. and both mycosis and fungoids, because they look mushroom-like and they are, you saw that they're fungal infection. There actually were proven later not to be. These are malignancies, a cancer-like process, although not all of them behave necessarily like cancer, which I'll discuss with you in a little bit. But we still use that term, but we understand that historically that term is incorrect. So mycosis fungoides are extranodal lymphomas of T-cell origin. They primarily involve the skin. They are the commonest type of cutaneous T-cell lymphoma, CTCL. They account for half of all cutaneous lymphomas. They are uncommon diseases. So we see like 3 cases per million and less than 1,000 cases a year in the United States. The peak age is 50 to 60. It involves males more than females, and it happened to be more in Afro-Americans. Cutaneous manifestations of the skin can really vary. What you look here are patches. Patches are patches and plaques. A patch is an area of the skin that's flat and is discolored. It could be itchy, it could not be itchy. If it is raised above the skin level that you can actually feel it, it then becomes a plaque. If it forms something that's lumpy, it becomes a tumor, or if all the skin is red and very itchy, that's what we call erythroderma. So these are the 4 primary appearance or manifestations in the skin, and they follow the staging system in the skin as well, which I'll show you in a minute. The diagnosis is based on skin biopsy, and the typical appearance is what we call Potrier microabscesses. And important to note, these are not present in all cases. If you have had multiple biopsies before you receive the diagnosis, don't be discouraged because that's fairly uncommon. The typical patient would have had 3 biopsies in their lifetime before they receive the actual diagnosis. And the reason for that, because that disease happened in a continuum, and the earlier skin biopsies may not be diagnostic. Some patient would have those what we call circulating Sézary cells that have a typical appearance. Sézary syndrome is a little bit different. It is where the whole skin is red, hot, and itchy. It could and is frequently associated with bacterial infection with Staphylococcus. Typically, patient would have circulating cells, but they don't necessarily have to be. One important thing to notice that in that situation with the erythroderma, skin biopsy is not necessarily diagnostic, it usually isn't. And that tend to overlap with other skin disorder like skin atopy, which is some sort of an allergy, and other inflammatory skin condition. Some cases are very hard to distinguish from another skin condition like psoriasis. So how does CTCL start? I don't think we really actually know up to this date. We know few things. The disease usually starts what we call in a polyclonal fashion. What does that mean? The hallmark of cancer is being monoclonal. Monoclonal means all the cells are born out of one single cell. They're all identical, as if they are twin brothers or sisters. But in CTCL, the confusing part about the biology as well as the diagnosis, this disease typically starts as polyclonal, means that there is irritation of the cells. They are triggered by something. Frequently, it is staphylococcal infection. And then they start growing. And then if you analyze those cells, they don't necessarily are all from one clone. They're not identical. And that's why exactly the early skin biopsies in the course of the disease may not be diagnostic. But then those cells accumulate molecular abnormalities and they accumulate genetic damage. And then after that, when you do the skin biopsy, it will become diagnostic because you're able to find what we call a clonal signal. You're able to prove that all cells are born out of one parent cell. And then at the advanced stage of the disease with skin biopsy, with skin tumors or blood involvement, this is frequently where you analyze those cells. It looks like any other cancer, whether it's of the immune system or not. You're going to see a lot of genetic damage. You're going to see a lot of gene instability. You're going to see all of the genetic hallmark of cancer. So typically CTCL progresses biologically through all of those three stages. One important thing to note, not all patients necessarily pass through those three stages. There are some patients who start with an indolent disease and they remain indolent. There are some patients who start with an aggressive disease from the start. There are some patients who start with indolent disease and then it later progresses to an aggressive disease. And there have been a lot of effort trying to dissect and understand those different entities and what is the biology behind them. We have some what I call thought-provoking data, but I don't think we are yet at the point where we can run one single test, whether genetic or whatever, and tell which patient's going to behave what in the future. We'll spend the next few minutes to talk about staging. One thing to note though, staging in hematologic malignancy, blood cancer, is very different than solid tumors. With solid tumors, cancer starts in one organ like the breast or the colon and metastasize. That's not true for blood cancers. Some patients start out with stage 4 from the beginning and some start with stage 1. It is imperative that stage 4, the prognosis is worse than stage 1, but stage 4 is by no means a terminal condition because even patients who have stage 1 disease are not curable, because we believe that those diseases are systemic diseases. They are born out of cells of the immune system which are present all over the body. So that's why it doesn't make much sense that you surgically remove stage 1 disease, because it might reappear in other part of the body. And that's relevant for any kind of blood cancer, and it's a very important concept to understand. As a physician, I got frequently asked what stage it is, because patients are always under the impression of stage 4, there's nothing that cannot be done, but that's not true. So with stage 1A, we have patches and plaques only, but they're involving less than 10% of the body surface area. And we use the same scheme we use for burn patient to calculate the degree of skin involvement. If it's more than 10% of the body surface area, that's stage 1B. And if they have skin tumors, they are stage 2B. If they have erythroderma, where the whole skin is red, hot, and itchy, they are stage 3. If they have circulating Sézary cells in the blood, they are stage 4. Collectively, if they have patch plaque disease, we refer that generally for simplicity as early stage disease. While if they have skin tumors, erythroderma, or peripheral blood involvement, we refer to that as advanced stage disease. So this is one kind of simpler way to categorize or understand CTCL without, remembering all of the little nuances of the staging. This is an earlier study that's very important. This was based on the SEER network that's maintained by the National Cancer Institute, where all cancers are logged. And one thing to note here, this is a survival curve. So this is 100% of patients alive. And as the curve goes down, there are patients who die across the years. So one thing to note here, that stage 1A, the survival of patients who have stage 1A disease, is similar to an age and sex matched person of a general population who doesn't have CTCL. So that's really important. Patients who have stage 1A disease and remain in stage 1A disease, they have an excellent prognosis. They shouldn't, semantically think about themselves as having cancer. They have a blood disease that could be managed with topical agent, and they continue to do very well. Although some of them about a third would progress to advanced stage disease. And that's why frequent monitoring is very important. And as you see, as we move across the stages from stage 1A to 1B to 2A to 2B to 3 and to 4, the survival goes way down. So the staging seem to also is important because seem to predict survival of the disease as well. Bear in mind, this is an earlier study. Since we have those numbers, we have a lot of newer agents for CTCL. So these numbers about survival may not be true today as they have been back in 99 when this study was published. Ideally, for the best outcome for a cutaneous lymphoma patient, a multidisciplinary team is key, and that's why there is a lot of emphasis on what we call centers of excellence, which are usually large academic medical center where you have physicians and other specialists who have expertise dealing with those rare conditions. The ideal scenario would involve a close collaboration between a hematologist and a dermatologist. And in an ideal scenario, the same center is able to perform bone marrow transplant, and hematologists who have expertise in that disease can identify the patient who benefit from that procedure that can be curative early on. You need an expert dermatopathologist in the lab. That's a person who looks at the slide and makes an accurate diagnosis. If the situation involves skin tumors, which are open, you would need the help from wound care specialists and sometimes plastic surgeons. And radiation therapy had a very important role in the management of CTCL. So in an ideal center, you would have access to all of those specialists, and they work together in close collaboration. And multidisciplinary clinics are very popular in those centers. And I believe they provide an above and beyond care, which is usually otherwise fragmented at least in the United States. So let's talk briefly about treatments, and you will learn more details about that from the other excellent speakers lined up in this conference. I'm sort of sharing with you a few sort of key concepts or broad strokes. Given that patients who are diagnosed with these conditions, CTCL, they have a long survival, particularly with early stages of mycosis fungoides. Physicians are frequently advised to experience therapeutic restraint. So if you have a patient who have patch and plaque disease, you shouldn't be using chemotherapy for those patients. You should be using what we call skin-directed therapy. And what we call complete remission, using the same criteria we use for other kind of cancers. This is kind of unusual with these diseases. They're usually resistant to treatment. So what we call complete remission rates are kind of typically low. They're about 10%. And newer drugs could be approved by the FDA to achieve 30% response rate, which is basically means 30% improvement in the skin. And as opposed to other areas of oncology, treatments that have failed before, they could be retried again in the future with some success. So it's very common to sequence treatment. I could start with one topical agent and it's not working, and then I could give the patient another topical agent, and then I could refer them to radiation. And then when the disease comes back, I could go back to using the first topical agent that failed in the beginning and still get a response. So stable disease in that sense, if there's still some patches and plaques, but the patient is no longer itchy and they're feeling well, they have a good quality of life, that's not considered a treatment failure. Frequently, we treat to try to improve symptoms. And up to this DNA age, nobody is able to prove that treatment of early stage disease does improve survival. And that's hard to prove, given that the survival of early stage disease is almost similar to a general population. So it's really hard to design a study or a clinical trial that will prove a survival advantage. So treatment of early stage disease, patches and plaques. is usually, at least in the United States, managed by a dermatologist. And frequently topical agents are used. They could be steroids or other forms of topical chemotherapy. Bixarotene is a vitamin E analog that's very popular and is used both topically as a cream, or it could be given as a pill. There are other topical agents in use as well. You could use light therapy, which is typically given by a light box in a dermatologist's office. And there are two different kinds of that. There's called what we call narrowband, UVB, and PUVA. The narrowband is typically they sit in a light box, which is some sort of a sophisticated tanning bed. Like frequently, sometimes I would see patients who live in a very rural area and they have no dermatologist office close to them where they can get narrowband. So then we advise them off-label to go and just use a tanning bed, and they can achieve a similar result. It's certainly not ideal because with a narrowband, the dermatologist will be able to adjust exactly the dose to be given, but we're usually able to give them some sort of a rough approximation. With PUVA is different because they receive a photosensitizer, what we call methoxysorelin, and then they get exposed to a different wavelength of light. And it seemed to be more potent and have a deeper penetrance. So it seemed to be helpful in patients who have thick plaques where narrowband doesn't typically penetrate those. Sometimes you could see even response in some non-bulky tumors with PUVA. Oral bixarotene, which is a vitamin E analog, is very popular. It's usually very expensive as well, but there are multiple patient assistance programs to be able to get that if needed. It's very effective. It tends to mess with lipid level in the blood, like triglycerides, and also mess with the thyroid function. And your doctor should be monitoring those very closely when he starts you on that treatment. There's interferon, which is typically given by injection at home a couple of times a week. Interferon is the same substance as the body produces when a person has a flu or another viral infection. So when you receive interferon, it's normal to feel achy, tired, have a low-grade fever, as if you're having a viral infection. And some patients seem to be more sensitive to those side effects than others. And then combinations of different things are popular. So a patient could be on both bixarotene or interferon. They could be on bixarotene and narrowband, and they seem to be synergistic. So combination treatment seem to be also quite popular if needed. For advanced stage, because there is no curative treatment short of bone marrow transplant, comorbid conditions are a key. CTCL is typically a disease of older adults, and that's why it's important when you pick one treatment to give that you'll be quite mindful of what are the other comorbid conditions that the patient have. There's some agent that can cause inflammation in nerves, neuropathy. So if the patient have already advanced neuropathy from diabetes, then that wouldn't be a good choice. There are some other agents, if you're using chemotherapy, that cannot be used because of problem with cardiac conditions or so forth. You have to look at liver and kidney functions as well. So there's a lot of things to be taken in account when you pick what's the best treatment. You should, I'm usually talking to physicians, so I say you should. So physicians should identify transplant candidates early on. They're usually younger individuals who have an aggressive kind of a disease, and they refer them to be evaluated for a bone marrow transplant early on, because that's the only modalities that have been proven so far to be curative for that disease. Cure rates are not high, though, to bear that in mind. But sometimes it sort of resets the disease to an early stage that becomes more manageable. In essence, with bone marrow transplant, you're installing a new immune system in the body. That's the whole purpose of doing that, but that just certainly comes at a price as far as infection and other immune complications. It's recommended that all patients are referred to clinical trials as possible. I'm a strong advocate for clinical trials because none of the current treatment we have are curative, and all of them are associated with significant side effects. There are some drugs who work in different compartments of the body. So some drugs work better in the skin, some work better in the blood if there is involvement of the blood, some work better in lymph node if there is involvement of the lymph nodes. Symptomatic treatment for pruritus of itching could be challenging, and that's why a close collaboration between a hematologist and a dermatologist in a tertiary medical center is key to have the best outcome. It's important if a patient is doing well and suddenly their skin seems to be red and hot and they develop what we call erythroderma, that blood culture should be sent because they may not have disease progression. They could simply have staphylococcal bacteremia. And if you treat that, the skin will improve. There have been some cases where there are remission of patches or plaques or even skin tumors when a staphylococcal infection have been treated. Where there's erythroderma or Sézary syndrome, the treatment is slightly a little bit different than mycosis fungoides. Extracorporeal photopheresis is a popular way to treat Sézary syndrome and erythroderma. It's usually prescribed 2 to 3 times a week. And the way it's done, the patient comes to a center where that's available. He sits on a blood bank machine and it draws their blood and it goes in there and be exposed to light. They are given usually Sorrelin in advance, which is also a photosensitizer, the same that's used for PUVA. The problem was, there are a few problems with ECP. It's not widely available for patients who live in rural centers. It's usually prescribed few times a week, which can become cumbersome if patient doesn't live near such centers. The blood needs to flow into a machine at a certain rate, and sometimes patients don't have good veins to have that accomplished. So they need to have some sort of a dialysis or a central line placed. And that line can become infected and create additional problems. It seemed to work better for erythroderma or Sézary syndrome, but there are also responses in early stage CTCL. Responses could be improved when it's combined with bixarotene and interferon, and responses seem to be higher if it's employed early. There is some emerging data that ECP is particularly an attractive option because compared to the other treatments of CTCL, it results in immune activation rather than immune impairment. So it's not an immunosuppressive treatment. It does not suppress your immune system. It just has its own sets of challenges, but certainly it had its own attractions as well. So just to review with you what we call the current treatment landscape for CTCL. For stage 1A and B, we could use steroids topically as creams. We could use other agents like topical mustard with the chemotherapy, topical bixarotene or imiquimod. Imiquimod is another topical agent that works by attracting immune cells to the skin. For early stage disease, especially if you have more than 10% body surface area, it's hard to apply cream to a large surface of the body. It becomes impractical, especially if it involves the back or areas where the patient cannot apply it, it's in him or herself. Then you could use light therapy with a narrowband or PUVA. If there are localized tumors, radiation could be prescribed to those tumors. And there is a special form of radiation called total skin electron beam, which is also unfortunately not available everywhere, where radiation can be delivered to the whole body. And this is a very nice treatment and work for both patch plaque disease as well as tumors. There is a maximum lifetime dose that could all be delivered in one setting, but it's recommended that's divided over 2 or 3 setting, so it could be used in the future where nothing else works. Some patients can benefit very much from this and enjoy remission for a few years. I usually reserve this as a backup as I'm treating patients if they are not doing well or they're frustrated with the treatment they're receiving, I send them to get total skin electron beam and get some relief for a few years until we can line the second treatment for them, whether it's a newly approved treatment or perhaps another clinical trial. Photopheresis on its own as single agent or combined with pixarotene and interferon is employed typically for patients who has erythroderma or Sézary syndrome. Then the home systemic treatment like oral pixarotene, vorinostat is another agent, or interferon that's given subcutaneously. Typically, the patient gives to himself or herself at home. Usually are employed at stage 1B or higher, but they work all across all stages. Once we're dealing with more advanced stages, we start using the kind of treatment that are typically given in an infusion center. Brentuximab and mogamulizumab are two newer agents that were recently approved and are associated with very nice responses, although they have their own toxicities. Romidepsin is also another agent that's very popular and for cutaneous lymphomas. Those agents have their own sets of toxicities and problem, and certainly talk to your doctor in detail and understand all of what you expect when you start those kind of treatments. Bone marrow transplant, as I said earlier, could be employed in highly selected patients who are younger and fit and have an aggressive disease. And I would say that clinical trials should be recommended across all stages, even at early stage disease, because currently we don't have any curative treatment. I want to talk about few other less common T-cell lymphomas of the skin that are important to be aware of. Lymphomatoid papulosis is one of those. And this is a benign behaving disorder where a patient would develop crops of lesion involving the skin. They usually become pustular and they shed off and fall over weeks. One key thing is to be aware of that rare disorder, because if a biopsy is taken, the appearance under the microscope could be fairly scary, and the pathologists have no way of knowing that this is lymphomatoid papulosis unless he's provided with a history. If he looks at it under the microscope without giving any clinical information, he could think that this is a very aggressive systemic lymphoma involving the skin. It looks exactly the same when you biopsy it. And hence a close collaboration between a dermatologist, a hematologist, and the pathologist who reads the slide is key to reach an accurate diagnosis. This disease responds well to a low dose of methotrexate, which is a very mild chemotherapy, usually given to patients who have rheumatoid arthritis or other autoimmune diseases, and it could lessen the severity of the flare. Many of those diseases, many of those patients live a normal life, and this become more a nuisance than a real illness. Patients who have more advanced stages of this condition, which is unusual, can respond very well to the agent brentuximab vedotin. There is another condition closely related to that. It's called primary cutaneous anaplastic large cell lymphoma. It could overlap with lymphomatoid papulosis. The difference is there is usually one predominant lesion, although there could be a bunch of lesions. The lesion usually becomes ulcerated and scabs. Usually staging is recommended to make sure there is no systemic disease. And if it's one lesion or multiple lesions that could be involved into one radiation field, enclosed in one radiation field, you could give one dose of radiation and result in a cure, although recurrences are common. These diseases also respond very well to brentuximab vedotin. Spend the next few minutes to talk about the cutaneous B-cell lymphoma. So these are diseases that come from the other kind of immune cells involving the skin, the B cells. I'm going to discuss the first three, which are the commonest that you would encounter. And then the other are rare enough that we're not going to be discussing today, but I'll be glad to answer any questions about them. We'll first talk about primary cutaneous marginal zone lymphoma. It's an indolent lymphoma. It's considered a mucosal lymphoma, similar in biology to the one that involves the stomach or the gastrointestinal tract. usually presents as violaceous plum-type plaques and usually treated with a topical agent because this is sometimes tied to some sort of bacterial infections. You could try a long course of doxycycline for 2 to 3 weeks, and sometimes that can result in remission. Some of those cases are associated with a hepatitis C virus infection. And there was a recent report from our European colleague showing that if you treat hepatitis C with a newer non-interferon type oral regimen, the primary, the marginal zone lymphoma, whether it's cutaneous or systemic, could actually enter remission if you treat hepatitis C. A patient who has this condition typically have excellent prognosis. It's important to do staging with scans, make sure there's no systemic disease. But recurrences are common and they're not the sign of any badness. You could treat the disease. In another few years, a patient could develop more lesion and you will continue to treat and they will continue to enjoy a good quality of life. Second condition I want to talk to you about is primary cutaneous follicle central lymphoma. This is another indolent condition. It usually presents on the scalp in elderly patient and usually presents in the head and neck area. Under the microscope, the pathologist can check few markers that can be able to give him an idea if this is truly a primary cutaneous B-cell lymphoma or its involvement of the skin from a systemic lymphoma. And you could use that information to decide if you're going to get CAT scans or not, or I mean your doctor would. It's usually treated with local measures, with topical agents, or you could give one single dose of radiation. And recurrences are common again, and it's not associated with poor prognosis. And in extensive cases, could use an infusional treatment called rituximab that's frequently used in patients with B-cell lymphoma. The other type is a diffuse large B-cell lymphoma of the skin, usually what we refer to as quote-unquote leg type. And as it's called, this frequently involves the lower extremities or the lower half of the body. It's typically affect older women, and it's not as good of a prognosis of a disease. Usually present with red bluish tumors on the legs. As you see here, the 5-year survival is only 55%. And usually treated as a systemic lymphoma. So frequently those patients would require chemotherapy type treatment along with rituximab, which is immunotherapy. I have sometimes patient based on preference just use immunotherapy and radiation, but this is by no means standard. And recurrences are fairly common. This disease, after treated, it could also come back as a systemic lymphoma. I hope this was not a lot of information and it was helpful to you during your journey. This is our Bing Cancer Center where we have our new program for blood cancers. And I see a patient there with cutaneous lymphoma based in Columbus, Ohio. Thank you very much for your attention, and I'll be glad to answer any questions you have.
Thank you so much, Dr. William. That was a great amount of information. So as a reminder, in your portal on the right-hand side of the screen is the live Q&A. If you drop down on that little arrow, you will be able to enter your questions. I have a few questions all ready to get us started. So our first one is, I am newly diagnosed. How is this a blood cancer that isn't in my blood? Additionally, it presents in my skin, but is not skin cancer. How does that work? And this is a question that is very confusing for many newly diagnosed.
It is extremely confusing. And I tell you, even us who are experts in the disease, we are yet not able to answer. Is this disease starts in the bone marrow and moves to the skin? Or it starts in the skin and moves to the blood? That chicken and egg question, we're still not able to answer till this date. So we don't really know. What we know is it's a cancer of immune cells. and it's born out of immune cells. So it's not a skin cancer. When we say skin cancer, we typically talk about a cancer that come from cells of the skin. These are not cells of the skin. These are cells of your immune system. So they come from the blood and go to your skin to serve a purpose, which is fighting infection and protect the skin. But do they become malignant in the blood before they move to the skin, or they become malignant right in the skin? We don't know yet, but they are blood cells. That's why it is a blood cancer, but they are not, there are no malignant cells in the blood. I hope that answers your question.
I think that was very helpful. Thank you. So we have a few more questions that are coming in, so bear with me as I read through them and on my pronunciation on some of the words. So can you elaborate more about the cause of MF? I think you mentioned, but I can't even say the follicular infection.
Yeah. Yeah, we don't really know. We have some clues. So the closest thing we know of is staphylococcal infection. Staphylococcus is the bacteria that causes boils and skin infections. But we all get boils all the time, and not all of us get mycosis fungoides. We don't know why, but some individuals seem to be more predisposed when they get chronic exposure to a staphylococcal infection, to that sort of immune irritation that after a while, it turns into a cancer. It's like if you have a wild animal in seclusion, and after a while, from constant irritation of that animal, after a while, he becomes crazy. It's one way of explaining it. So with constant irritation of those immune cells, they keep fighting that infection. But after a while, in their desperate effort to do that, they turn into a cancer. This is the best that we understand, but this doesn't answer all the question. Staphylococcal infection is very common in mycosis fungoides, but it's not universal. And sometimes you treat the staphylococcal infection with antibiotics and patient enter remission. But sometimes you treat them and they don't enter remission. So it's only part of the puzzle, but it doesn't really answer all of the aspects of the disease. The disease itself, up to this day, to my knowledge, remain largely an enigma to us.
Okay, thank you so much. As a reminder, I'm going through some of these questions, and some of them are very specific to your cases. And while we can share information and knowledge on some of these, it's not really possible for Dr. William to answer, because he would need to be treating you to be able to give a correct answer on it. So I have one here, and the question is, does CTCL make us more susceptible to other cancers?
Yes, certainly so. And I have published on this when I was at OSU. Even patients who have early stage disease like 1A, we were able to show immune dysfunction in different immune compartments, including natural killer cell. And there is a few studies that shown that patients who have cutaneous T-cell lymphomas are at a higher risk to develop other cancers, even solid tumors. Now, what to do with that information? Certainly, one thing that's not helpful is to worry to death, because that's not going to help anyone. I would say is just be diligent in bringing any new symptoms or concern to your doctor. Do all of the recommended cancer screenings that your primary care physician recommends. So don't delay mammograms, don't delay colonoscopies. If your doctor wants to screen you for prostate cancer, go ahead and do that. So do all screenings diligently, do not delay them, because many of us, we are busy, and if we are not, it's very common to delay screening studies. But I would say be diligent in the cancer screening. One thing that you certainly should not do do not demand out of your doctor to like get you a CAT scan of your whole body once a year. That's usually is a very terrible idea. In my experience, when we do that, we find things that are meaningless. We worry about them and we don't know what to do with them. And sometimes they're very small for us to biopsy. And then we're stuck, or sometimes we biopsy and then we encounter bleeding or infection or other problems. So it sort of opened the Pandora box unnecessarily. I would say shortly, yes, it does increase risk of other cancers, but the best way of dealing with that is to remain hopeful and positive. Bring new symptoms to your doctor, even if you're not sure what they mean. He or she would be able to answer that for you, and do all your recommended screening at the recommended times without delay.
Okay, thank you for sharing that. So we have a question on the differences between T cell and B cell. And what the question here is based on the information you gave on T cell, like staging, does it apply also for B cell? This particular person had 3 biopsies before they received their diagnosis, so they're wondering on the similarities.
Yeah, B cell, there are different ways of staging B cell lymphomas. I think for all practical purpose, the main question about cutaneous B cell lymphoma is, are they in the skin only, or they are in skin and other organs? If they are somewhere else, they are systemic lymphomas with involvement of the skin. And they are usually treated as systemic lymphomas are treated. If they are in the skin, they're usually treated by a local measure, which is usually a topical agent or radiation. This is a very simple way of thinking about it. With B-cell lymphomas like T-cell lymphomas, yes, it is not unusual to have had multiple biopsies before an accurate diagnosis is made. I haven't talked about that quite a bit, but the method of biopsy is also important. So some of the procedures that you can get in a dermatologist's office, like a shave biopsy, it's not very helpful in reaching a diagnosis. You need a full sickness skin biopsy to get a diagnosis. So if your first biopsy was a shave biopsy, that necessarily will not be able to answer if it's lymphoma or not. Lymphomas in general are different than skin cancers or solid tumors because under the microscope, cancer cells do not look very bad like skin cancer cells or melanoma. You look at the cell looks bad. You can tell that. You can stain it, and stains in a way that tell you that this cell is cancerous. That's not very hard in diseases like melanoma or solid tumors in general. But lymphomas in general, whether they are in the skin or not, you see a bunch of lymphocytes under the skin, and they look like they are there. So sometimes impossible for the pathologist, the lab doctor, to say, this is inflammation? Because if you have inflammation in the skin, there are autoimmune conditions like lupus, for instance, if you heard about that, or if you have had friends or family who had lupus. There is inflammation in the skin, there are lymphocytes in the skin. And it's hard to say, to tell if this is malignant or not, unless you have a good biopsy, unless you're able to run those ancillary studies, or sometimes the disease starts as inflammation first and progresses to cancer. Less common for B cells as opposed to C cells, but certainly non-diagnostic biopsies are not unusual in B cells by any means, especially if the biopsy was not adequate. I hope that answered your question.
And we have been compiling some additional data on B cell. Something I want to mention, there's a lot of great questions coming through, and we're not going to be able to get to all of them. We're down to about 10 minutes on this session. We will be having a clinical Q&A panel at 4 Eastern today. And what we're going to try and do with the questions we don't answer is see what information we have, and we will forward you that information. Unfortunately, we just can't get to all of the questions. So the next one we have for you, Dr. William, is I'm newly diagnosed and I'm on my second dermatologist. When should I see a hematologist?
Great question. I think that would be a good question to your dermatologist. I would say, as a general rule, there is no harm in seeing a hematologist even once. You could go there and see that doctor, and he would tell you that there is nothing in particular they recommend for you, and that's fine. So you could always ask your dermatologist that you would like to see a hematologist. Even better, what I recommend for you, if you have access, if you happen to live in a small town or a rural area, travel to a big city to the university and see a multidisciplinary center of excellence. Typically, when you go there, you will see both a dermatologist and a hematologist, could be at the same time or at the same day, and you get two opinions at the same time. I recommend you do that trip even once. You don't have to go there every 6 months or every year. Most of them will offer you that option, and most of them would be willing to work with your local doctor and be like a backup or answer more complicated questions. That's a very common setup. When I used to run the multidisciplinary cutaneous lymphoma clinic at OSU, and I'm building something similar at OhioHealth now, we would work closely with many different community dermatologists. Patient would come to us from a small town. We make a treatment plan and we send them back to their doctor, and we see them once every 6 months or once every year or once or later, depending on what they choose. But then we will be able to provide an opinion, and most of the time, the dermatologists are usually happy with that visit, that we're able to sort of endorse the recommendation or provide perhaps an additional insights into the treatment. So ask your dermatologist to place that referral for you. He or she would be able to recommend a center of excellence for you.
All right, that's good to know. And it's always good to know that you can ask and ask the questions. It's always important to ask whatever questions you have. Okay, so this next question is very specific to MF, but I think we would want to answer it in general because we do get a lot of questions about being immunocompromised. Does early stage MF make you immunocompromised? So if you can answer that, and then in general, having cutaneous lymphoma, how it affects that.
The short answer is yes, but how much and what you're going to do about it is what's relevant. Certainly, my recommendation is, by all means, do not live in a bubble. Go out, enjoy community activity, and enjoy life with prudence. Means, if you have not been vaccinated for COVID-19, please get vaccinated. This is a medical statement and not a political statement. If it is recommended that you use masks in big gathering, use masks. Most infections, really, including COVID-19, you would acquire that by contact method and not by droplet. Droplet is not very efficient in, no, I mean not droplet, I mean airborne and drop. It's not as efficient in transmitting things. The most common way you acquire any infection, viral, bacterial, or otherwise, what we call contact. Contact means I sneeze in my hands, I shake your hands, you take the agent and you put it on your mouth. That's the commonest way you would acquire an infection. So my advice to all of my patients, whether they have mycosis fungoides, cutaneous T-cell lymphoma, systemic lymphoma, any other kind of cancer who are getting an immunosuppressive treatment, buy a handful of hand sanitizer pockets, hand sanitizer bottles. Keep one always on you, perhaps in the outer pocket of your jacket or outerwear, whenever you are somewhere before you start eating, or maybe if you had to shake hands with somebody. Whenever you feel that you have been exposed to something, use hand sanitizer generally throughout the day. This is the single most effective way you can do to protect yourself. But certainly I wouldn't advise that you isolate yourself. Follow public health guidance now as far as COVID-19 is concerned, but otherwise do not isolate yourself.
Okay, thank you so much. Our next question is about remission. What is considered remission in early stage CTCL?
I don't know, and it doesn't matter because the key thing with early stage CTCL, are you happy? So when I treat a patient with early stage CTCL, my first question to them, are you happy? And that's a very sort of vague question, but it covers different things. Are they itchy? If they're not itchy, that's a great goal to be achieved. Are they bothered with the appearance of their skin? Maybe the plaque they have in a part of their bodies that's not exposed typically. So if that's okay, it's okay to walk around having skin lesion if they're not hurting you, if they're not itchy, if they're not bothering you in any way, if you're not sensitive about the appearance of your skin. That's a key thing, because up to this date, there is no data to prove that treating early stage disease changed the prognosis. So that's why what constitutes remission is unclear. To complete remission is unusual, and it's not really that important. Hope that answered your question.
Okay, thank you. So we just have a few minutes left, so we're going to try and squeeze a couple more questions in. Is there any correlation between higher seasonal temperatures and MF flare-ups? I seem to see symptoms in the past 3 years in summer months.
Maybe the data is conflicting. Actually, the sun seemed to be protective for MF. It seems like patients who live in areas of the country where they're not exposed to the sun a lot, they are the ones who tend to have more MF and more MF flares. Some patients get more MF flares with hot weather. That's certainly something I have seen. I can tell you that the data is really conflicting on that, to my knowledge. But my advice is do what works best for you. If it happened that you flare more in hot weather, then if you have the luxury of doing that, try to remain in cold, air-conditioned areas and do whatever decreases your flare. But that's all what I can say about this.
Okay, and everybody reacts differently, so it's kind of a tough one on that one. I think this might be our final question. Is what, and I'm not sure exactly if you can answer this one, but we'll give it a shot. Is what are the chances of moving in MF from stage 1A to 1B?
I don't think we have a lot of data about moving between stages. I can tell you that only 30% of patients who have what we call early stage disease, which is 1A or 1B, move on to have advanced stage, which is usually the one that threatens their life. So if you're 1A, you have about 70% chance of remaining 1A or remaining well throughout the rest of your life.
Okay. All right. We can squeeze one more in. And the question is how best to monitor indolent cutaneous T-cell lymphoma, and what is the long-term prognosis for this diagnosis?
The long-term prognosis, as I've shown you in those bunch of curves, is usually well. So if you have early stage disease, there is about 70% chance that you will do very well. The best way to monitor is to have what we call a total skin exam that's usually performed by an experienced dermatologist. And your dermatologist will be able to tell you how frequent he would like to see you. It's usually somewhere between 3 to 12 months. 6 months is being the most popular. They usually, when you come there, you disrobe. They give you a gown to wear because they want to look at your skin from head to toe. And as a bonus, they will be able to make sure there's no suspicious moles or any other things to worry about.
Okay, thank you so much for that. And with that, we are at the end of our session. I want to thank you, Dr. William, for your presentation and taking the time to answer these questions. We're going to be taking a short break and hope you will be joining us for one of our next sessions. It will either be cutaneous lymphoma treatments early and late stage with Dr. Khan, or our pharmaceutical highlights roundtable with Susan Thornton. I also want to take this time to remind you that when we are done with the conference, you will be receiving emails with survey for the conference, and we're hoping that you will complete them. It's very helpful for us to get these surveys to find out what we did right and what we could improve on in the conference. And this year, we will be drawing names for a special gift for everyone that completes the survey. Not for everyone, from everyone that completes the survey. So thank you so much, and I hope to see you in our next session.